So I think, Maurizio, we are ready to start.
Yeah,
It's 1:30, so perfectly on time.
I'm ready.
Great. So just to say hello to everyone and thank you very much to Professor Cutolo, who's the first one to give the webinar for the year-end ReCONNET. So we're starting this new activity and we're recording the activity as well. So thank you very much, Maurizio, and we are looking forward to hearing you and your presentation. Thank you very much to all those who are able to attend.
All right, Marta and all the team from Pisa, thank you for the invitation. And has understood that this part of the ReCONNET activities also to introduce some sort of education, some topics and arguments that may be interesting in the management of our patients. The title of my presentation should be related to the real roles of vitamin D. And it's much more complex than you can imagine, what we have discovered in the last decades. So, basic concept is that vitamin D is not a true vitamin. In fact, every one of us with an adequate exposure of the sunlight do not require to introduce vitamin D, because vitamin D is a producer in our body. 80% is produced by the sun exposure. This is an important concept. And in addition, vitamin D is not a vitamin, even because it's a true steroid hormone. It's an hormone. And we will discuss how and why is it a hormone and not a vitamin. The history of vitamin include, of course, an important concept that is related to the bone regulation. We know very well how important is the role of vitamin D from the beginning, involved in the calcium uptake, balanced calcium phosphorus, increase in bone turnover. So this for sure is an important action of vitamin D. And it's well known that in both primary and secondary osteoporosis, the role of vitamin D is important together with calcium. But it's not all. When we move to the connective tissue disease and we remember what we discussed at the beginning, that vitamin D is true hormone, steroid hormone, here we must consider how is important this discovery that is 120 years ago. Vitamin D has the same structure, start from the structure of cholesterol, like a glucocorticoids of sex hormones. And so sharing the structure with steroid hormone, it's not a surprise that vitamin D modulates in some way the immune system. So when we discuss the connective tissue disease, of course, we have a panel of disease with a different localization. The target organ are different, but the pathophysiology and the risk factors in terms of, for example, deficiency are almost the same. And all dealing with a complex network of the neuroendocrine immunology. From one side, the central nervous system and the peripheral system. From the another side, the immune system with the different players, from the antigen-presenting cell, macrophages, T lymphocyte, B lymphocyte, and the other side, important endocrine organs that include the gonads, the adrenal gland with production of cortisol, the pineal gland, and this important hormone, vitamin D, calcitriol, that again, like sex hormone, cortisol, is synthesized from cholesterol. So it's a real and true hormone, the so-called vitamin D. If we want to look very, very fast to the synthesis, you see on the top, on the left, the cholesterol and all the different passages during the metabolic activities of our endocrine glands, producing mineral corticoids, hormones like testosterone, estrogens, glucocortisol, and finally the hormone, vitamin D. So all the steroid hormones derive from cholesterol, arise from cholesterol. All of them exert immune modulatory activities, even sex hormones, as we know, and all are decreased in patients affected by immune-mediated disease. And as I mentioned it, in 1927, almost 100 years ago, the role of cholesterol to vitamin D was already discussed in this very, very early presentation of the relationship between the vitamin D and its originator, the cholesterol. So we have two important systems of immune response, the innate immune response, and here the vitamin D, you will see, cooperate in the bacterial killing, defending from the infections. And on the other side, the adaptive immunity, the immunity that defends us or harm us with the self-autoimmunity that include the T lymphocyte, the B lymphocyte, and new population of TH. And here the vitamin D is generally a down-regulator of the adaptive immunity. These are two important actions because reflect the clinical condition and the risk factors. And generally, like glucocorticoids, vitamin D increase the anti-inflammatory cytokines like the Th2 lymphocyte H2 cytokines and the suppression of the helper T cells. So exert a real activity like cortisol, like glucocorticoids. And the research of vitamin D is increasing in the last years in a tremendous manner. If you look at the production of paper studying vitamin D in 95, you find 1,000 items. And if you move after 10 years, you find 1,600 items. And if you move again in 2015, you find 4,100. So vitamin D is part of the most important and many important research dealing with even connective tissue diseases. And if we look at the last hour's investigation, like 2020, there are already 22 papers on vitamin D that are dealing and will be published from January or February. So we are in 2019 with 4,400 papers that are involving vitamin D as one of the topics. Almost 400 investigation and even more a month. If we look at the history of vitamin D in the sera of humans, we know that the human evolution means less exposure to the sun. And like this follow the vitamin D deficiency. And the animal we are work at the PC, we are completely different from the originators. So if the mid of the 20th century, the concentration in the healthy subjects were around the 50 nanograms that we consider sufficiency, today in the worldwide, the concentration is less than 50%. So it's clear that less sun, less vitamin D. There are differences between countries, between age, and so this is important because even the season, that means in winter less sun and in summer more sun, induce strong difference. You see in winter, in Europe, for example, and in summer, in young adults and elderly, in both situations of the life, the concentration of the vitamins and the vitamin D is much lesser in winter than in summer. And you compare also the Americans to the Europe, you see the difference. This is a very important point because the pathway of vitamin D starts from cholesterol, the cholesterol of our skin that is particularly precursor of the final cholesterol, 7-dehydrocholesterol, that is transformed by ultraviolet in cholecalciferol. This is a precursor of the final vitamin. And then through the liver to the kidney, we produce the final calcitriol. But attention, because even peripheral cells in our body, in particular the macrophages, the cells of the immune system, are able to produce themselves the final hormone, the calcitriol. And this is really important because when we get a disease, at the site of disease, there is a high concentration of macrophages, like on sarcoidosis. And vitamin D means more absorption of calcium. And in sarcoidosis, we observe more calcium in patients. So peripheral cells play a role in inflammation, play a role in proliferation, and some of the actors for such anti-inflammatory action, it's a vitamin D, the D hormone produced by the cell's self. So even if the kidney is not efficient, the peripheral cells mutuate the action. Very important concept, this one, because we must consider the rhythms of our planet. We have a known, random, continuous alternance of the light and of the darkness. So we have the day and the night, and we have a revolution of the earth. So we have the seasonal changes, summer and winter. And this is predictable and is recurrent every year. So every year there is a different distribution, for example, of vitamin D according to the season. But generally, where less the sun is present, less the vitamin D concentration in the serum is available. So you see the red one in areas where the sun is less potent and the sun ray being are horizontal, the action of vitamin D, of the ultraviolet on cholesterol of the skin and on the synthesis of vitamin D is less potent. So the maximum is around the equator. And if we look in the United States, for example, from January to December, and you look at the concentration of the UV and vitamin D, you observe that winter again, down, sun, down the vitamin D in the people living in these areas. It's interesting because in normal human, related to the season changes, we have also changes in immune response and physiology of the immune system. If in summer we have less cytokines, for example, IL-6 is produced less, or mediator inflammation like other cells, the B cells that produce antibodies, or marker of inflammation like C-reactive protein, CRP. On the other hand, in summer we have the highest concentration of the receptors for vitamin D, so the vitamin D may act, and act how? Down-regulating physiologically in normal subject the immune response. Very important aspect, because this action is an epigenetic action, and the genes of our DNA are modulated by the concentration of this steroid hormone. So if we move at this point to the seasonal variation in vitamin D levels, and on the other side, the concentration of the cells that do the immune response, we observe that in summer, we have the highest concentration of vitamin D. Both the precursor and the hormone, 125 hydroxylated, that the function of vitamin D is the true hormone. Summer, the highest concentration. Winter, the lowest. And even spring, the beginning of spring. And looking at the cells of the immune system, if we look, for example, at the lymphocytes, T lymphocytes producing, for example, IL-17 as a cytokine, in summer, the lowest concentration. So the immune system is working less in summer. It's in vacation in some way. So in healthy individual, there is a continuous modulation of the cytokine production that is much higher in winter than in summer. Again, IL-1, TNF-alpha, IL-6, interferon gamma. You see all the cytokines shows lowest levels in summer and of spring. So this should be very clear. Vitamin D is an hormone, a D hormone with steroid structure, and exert down-regulatory activity like odor, like androgens, like cortisol. And so vitamin D is an important down-regulator. It's important to get the right concentration in our body. If you look at the Actually, they are inhibited by vitamin D concentration. You see again the cytokine, pro-inflammatory cytokine, the proliferation of the cells, the production of antibodies, the production of cytokines like IL-17. And you will see how this is interesting, because now we know that psoriasis comes in winter because the IL-17 increase, because there is no inhibition by vitamin D. And so, on the other side, we have enhancement in normal condition of the anti-inflammatory cytokines, like IL-10, TGF-beta, IL-4. So, this is a true hormone. And it's really interesting to see how was understood already 100 years ago that letting the patient with chronic infection by tuberculosis, for example, all day on the sun, the sanatoria, the patient improved. And the tuberculosis chronic was in some way controlled. So a high proliferation of sanatoria or solarium at that time. And in 1855, a Swiss doctor got the Nobel Prize because he discovered that the sun was able to reduce the cutaneous tuberculosis, at that time called lupus vulgaris, just with the sun. He discovered that the sun improved the cutaneous tuberculosis and also lung tuberculosis, and he got the Nobel Prize. And from that time start the story and department of light, for example, at the London Hospital, to study the effect of the sun on chronic infection. And this is true, because when I told you that the cells of the immune system are capable to synthesize vitamin D, and vitamin D acts as a bacterial killer inside the phagolysosome, now it's clear the antibacterial activity of macrophages in the granuloma explain the success of the sun to protect from the infection. And effectively, we get less infection, even the simple bronchitis in summer, much less than in winter. In winter, vitamin D is lower. And macrophages, with all the other cells, are the players. So, in few words, no sun, because winter, latitude, sunscreen, use it too much, mean less availability of vitamin D, so vitamin D deficiencies. Consequences, even depression, because cortisol help, sun help also the synthesis of cortisol. And autoimmune disease like type 2 diabetes, or type 1, of course, but also many autoimmune diseases, including type 1 diabetes, multiple sclerosis, Crohn's, rheumatoid arthritis, and even, unfortunately, cancer. But we don't discuss in this meeting about the role of vitamin D in cancer. In rheumatoid arthritis, this very interesting study was produced by a French committee. They went to see the onset of rheumatoid arthritis. It was in summer, in autumn, in winter, and spring, and went to analyze the severity of rheumatoid arthritis and the progression of rheumatoid arthritis and the level of erosions, and the level of erosion and the damage and the severity of rheumatoid arthritis was much higher in patients that started the disease in winter. And winter, again, one of the risk factors for the less efficient immune system, less efficient suppression of the immune system, and the vitamin deficiency. So again, low vitamin D, less control like cortisol of the anti-inflammatory cytokines, and less easy to have B cells activity, lymphocyte B or antibodies, cytokines, TNF-alpha, and so on, and IL-17. We produce a study with EULAR as a supporter, looking at some of the risk factor or situation or clinical condition that may tell us, be careful, you have a deficiency of vitamin D. And at the end of this study, looking at the symptoms like nail fragility, hair fragility, use of milk, and so on, we found that vitamin D serum concentration were negatively correlated with the global risk factors, with the quality of life, as well as in a cohort of patients with rheumatoid arthritis with the clinimetry that include DAS or RIDE score. So vitamin D is even connected with the symptoms with severity of the disease. But much more interesting is in psoriasis and in psoriatic arthritis for the effects we mentioned on downregulating IL-17. You know that today with successful psoriasis is treated with monoclonal antibody that block IL-17. And here was evident that in any case, vitamin D in the arthritis, psoriatic arthritis, reduce also the activity of important phagocytic cells like macrophages or osteoclasts and reduce the erosions. But as I mentioned, vitamin D contrast modulates the Th17, the production of IL-17. So when we use the true hormone 125 hydroxyvitamin D, that is the final product of the synthesis I mentioned, we do a real, in some way, hormonal therapy, intracellular hormone therapy, and high level of vitamin D treat psoriasis. If you go in summer on the sunlight and the transformation on the skin of the cholesterol in vitamin D downregulate the Langerhans cell and downregulate psoriasis. And 1 week of sun may reduce the psoriasis. And here you can see, sorry, a clear example how the association of vitamin D and cholesterol increase the downregulation of the lesion, a synergistic effect. Cortisone plus vitamin D exert an important downregulation. And even the sun exposure do this. And now we know that the bridge between the action is the vitamin D. And so again, other studies showing how is excellent this synergistic action between vitamin D, the D hormone 125, and cortisol. When you combine both, you get really exceptional results. You can see here the combination. Calcitriol is able, steroid is able with some side effects. The combination is fantastic, but on TNF-alpha, for example, you see that vitamin D is an even more efficient than cortisone, a glucocorticoid, in reducing the percentile, the increase the production of the pro-inflammatory cytokines. And in lupus, what happened in lupus? Vitamin D is associated with a more active disease in patients with the deficiency of the hormone. Higher concentration of antibodies, much more evident in patients with low levels, under 20 nanogram per milliliter. So this is really important because, again, strongly support the concept that vitamin D downregulate the B cells that produce the antibodies. So lupus, of course, we know very well that lupus patients, when they are exposed to the sun and to the UV, get much easier skin lesion. But here we can use the analogs. So we give by oral way substitutes of vitamin D that must be absolutely introduced in the therapy of lupus patients when the concentration are low. And so there is a clear evidence that the change, seasonal change in the concentration of vitamin D may trigger SLA in non-African. Here, the role of melatonin is a sort of barrier for the true action, and the severity of lupus we saw in the Black people is stronger, less vitamin D. So this important role of vitamin D on the different players of the immune response, it's evident, especially when we get the deficiency. At this point, we can say in conclusion that for sure, the immunosuppressive efficacy of the D hormone now is quite well established in normal subject, in patient with connective tissue disease and action of the immune system. And especially it's evident, it's clear how the sun improved psoriasis. Now we know because. Why? Because the vitamin D is deficient and the IL-7 is produced, the cell, the lung cell producing the vitamin D are very sensitive to the downregulation of the D hormone. And the serum deficiency of vitamin D is the most evident in all patients with connective tissue disease. Maybe due to the diet, maybe to the use of drugs, maybe to the less exposure to the sun. Altogether are causes of these important risk factors, low levels of vitamin D. And so vitamin D, the D hormone, acts as a real steroid hormone. Further studies need to better understand how to substitute the deficiency using the different D analogs, since some side effects may be related, like increased calcium absorption and so on. But for sure, using the precursor today, we get results, we get improvement, and so we consider today the real role of vitamin D in connective tissue disease as one of the endogenous players that play as a natural down suppressor of the immune response. I wish you all, to all of you, a nice day. And of course, if there are questions, I'm ready to answer. Thank you very much and enjoy your day.
So thank you so much to Professor Cutolo. There's a question from Charissa Frank, our EPAG. You can read it in the question and answer panel if you want, Professor Cutolo.
One moment. I don't see the question on the panel, but I can do on the chat. Okay.
At the bottom of the screen, question and answer.
Okay. Hi, Charis. How is it for sarcoidosis patients who have high calcium vitamin D patient but high calcium? What you are suggesting if they also have arthritis psoriasis, for which vitamin D is important? For patients with sarcoidosis, as we mentioned, you know that they have a granuloma, the sarcoidotic granuloma, and the granuloma is formed by macrophages. So, unfortunately, you cannot stop the action of macrophages in this way because they will continue to exert this action. So, important to reduce in the diet the concentration of calcium, foods rich of calcium, in order to reduce the absorption. If they have psoriatic arthritis, in vitamin D is important. I think that the sun exposure is the best way, and you know that in all the lung pathologies, the exposure to the sun, it's really important, as it is a downregulator of the sarcoidotic function, of the granuloma function, like the granuloma in tuberculosis. So it's an indirect way, the sun and the action on the skin, to also reduce the macrophage action at the level of the sarcoidotic granuloma. Thank you very much. I hope you hear me or have to tape the answer, I don't know.
There is no other open question.
We would like to thank Professor Cutolo. Thank you, Professor Cutolo, for your very interesting and elegant talk.
There is a question.
There is another question, probably. Yes.
From Cristina Montes, yes.
Yes, the question is, I'm sorry I was late. I would like to know the normal levels of vitamin D, the best to keep. I have an antiphospholipid syndrome and seronegative spondyloarthritis. So up to now, in normal condition, during the year, you know that your lab showed 2 different levels in winter and summer usually. And in winter, the levels are lower, and this is the period to integrate. The lowest level acceptable is 30 nanomicrograms. So if you have less than 30, it's a real deficiency. Between 30 and 50 is considered acceptable. But to be safe and to enter the winter with a good reservoir, it's better to get your 50 nanomicrogram for milliliter. How to reach this? Usually with the daily administration of 2000 units of 25, one of the precursor of the final hormone, a day for 2-3 months, it's able to rise the levels in normal subject. In patient with chronic disease like your condition, should be better to test the vitamin D every 2-3 months to see if you achieve the levels I mentioned. Thank you.
So if there is no other questions, we thank you to all participants, and thank you to Professor Cutolo. Maybe Sara Tarico want to?
Yes, can you hear me?
Yep.
Yes. Thank you very much, Professor Cutolo, on behalf of all the network and ReCONNET for your very interesting and elegant talk. We are very lucky since Professor Cutolo is one of the major worldwide experts on vitamin D. So we are very lucky to have him in our network. If you have other last minute questions, otherwise you will find the webinar on the link of our website. Does someone have other questions? No, Professor Cutolo was very clear. So thank you again. Thank you so much.
Okay.
Thank you to all the participants. Thank you to all the participants. And see you to the next webinar as soon as possible. Thank you.
Bye.
Bye-bye. Thank you to all. Bye. Bye-bye.